So in the words of Monty Python, and now for something completely different. I am a pediatric neurologist, so like Jake, I take care of children, so I have to wear the obligatory sport coat as a pediatrician. As a neurologist, though, I'm actually also obliged to wear a tie. I think I'm the only one wearing a tie here today, but it's got some color, so it's kind of nice. But thanks to Jeff and Rod for inviting me and letting me share a little of my world with you. I think there's some lessons I can share of what's happened in the epilepsy arena. Ketogenic diets, mainstream. I mean, they are mainstream and popular, and how did we get there? It's been an interesting 100 years. A little bit of patience. I know people are not always patient, but it took some time, and I'll show you a little bit how we got there. I'll start with some history, and then I'll kind of bring you up to date on sort of how we do it, why we do it, and for who we do it, which I think is really important, especially for me as a neurologist speaking to other neurologists. We know it doesn't help every child. We know it helps certain children, and I'm going to speak a little bit about that today. So again, thank you. This is my first time at this conference. It's been actually really interesting. These are my disclosures. The one relevant here is the Atkins nutritional one. I'm on their scientific advisory board with Steve Finney and Sarah Hallberg. It's been awesome. It's been an awesome ride. I am the lone neurologist on the advisory board. I sit in the corner. They give me Atkins bars. And kind of like this meeting, I probably learned more from them being there than they learned from me. It's really actually been an incredible experience being on their scientific advisory board. So thanks to Atkins Nutritionals for that. Interesting history. So the idea of using diets or fasting for epilepsy goes very, very far back, probably to 400 BC with Hippocrates. And they really didn't even know what seizures were back then. They thought maybe it was possession or demonic possession. They really weren't sure, but they knew that periods of starvation would help. They thought maybe that it was ill humors and that by not giving foods that would provide those ill humors, patients would get better. And it actually worked. If you sort of read these articles way back, these references from Hippocrates, they talked about prolonged periods of fasting being helpful. And then Galen in 200 BC was a little more specific, again, getting to ungendered humors that may be necessarily negative. We didn't know exactly what was going on back then. This is where a lot of people think sort of the reference of using ketogenic diets for epilepsy goes back to. But again, it was probably 400 years earlier. But the widely described reference is from Jesus in Mark 9, where they talked about an adult who had what appears to be childhood onset epilepsy. Again, they didn't know what it was. The patient had a convulsion on the ground, and Jesus' prescription was prayer and fasting. Neither are bad ideas. And it worked, okay? And so they knew about this for hundreds of years, even through the Middle Ages, that periods of abstinence for whatever this condition was seemed to be beneficial. But it was 1921, actually it was July 27th, 1921. We're approaching the 100-year anniversary of the classic, as we call it, ketogenic diet for epilepsy. That Dr. Wilder, who was an endocrinologist, like Jake, at the Mayo Clinic in Rochester, Minnesota, created the ketogenic diet as we know it, mimicking what they thought was starvation. They said this is a diet that would be like fasting, but something you could maintain for longer periods of time. That's what the article describes. So this was back in 1921, almost 100 years ago. And we've had some changes. So the diet was very popular back then, but then new drugs came on the market. And for me in the epilepsy world, this is a good thing. I actually have a little bit of a different experience because, at least in neurology, my diet, so the ketogenic diet, is not really attacked, I think, somewhat like you may have in your field, so to speak. The drug companies are actually very interested in the diet, and we'll come back to that. But these drugs are great. Okay, it gives us lots of options for children, lots of options for adults. They all work somewhat differently. But when these came out in the 1940s, and we've had an explosion in the 1970s and 80s, the diet kind of fell out of favor. It was seen as expensive. It was seen as hard to do. Somewhat may be true, but again, was sort of lower in sort of the tier of our algorithms for treating epilepsy with all of these drugs out there. And so in the early 1990s, we in the ketogenic diet for epilepsy world were not in a great place. The diet was really kind of seen as a therapy of last resort, only in children, and for the most part, even in the early 90s, only in the United States. If you went to the American Epilepsy Society meeting, a great conference, you'd be hard-pressed to find anything about the ketogenic diet there in the early 90s. Maybe a poster here and there, but no sessions, no lectures, really very little at that time. Articles written about the ketogenic diet would put it into alternative medicine. We now consider it more non-pharmacologic. That's often where it ends up. But at the time, it was sort of perceived as alternative, and we really came a long way to say it's actually not alternative. It's just different. Now today, it is everywhere. It is all over the place. You've seen some great screenshots. I know the Wall Street Journal this morning, amazing. But this is from Time Magazine, New York Times. They love to show bacon all the time. I think it photographs well. I think that may be what it is. We always kid around about it. But the parents see this, and the parents are interested, and they're looking for other ideas for their children with epilepsy. And it's great that this is coming out in the popular media. If you were at a center outside the United States now today, you can find the diet. The colors, colored in countries here in dark are those that offer ketogenic diet services. Some of the countries, especially in Europe, may have multiple centers and even regional consortiums looking at ketogenic diet therapies, writing their own guidelines. So we often get contacts from families around the world. They say there's no ketogenic diet center in my country. I say not only is that not true, there's actually 7 in your country. And so it's really kind of exploding around the world. But as you can see, there's some areas that we have work to do. And I'll come back to that at the very end of my 30 minutes today. We are now organizing as a community. We just had our 5th conference back in 2016 in Banff. Beautiful, actually similar mountains here, although not as high elevation as Breckenridge. But as you can see in the bottom image, we had a lot of people, about 350, mostly neurologists interested in ketogenic diet therapy, come together to talk about how best we can use it. And so I'm often asked, well, what changed? How did the ketogenic diet become so mainstream in the neurology community for epilepsy? And I think there's sort of 3 things, and I'll come back to these in the next few slides. Number 1 was a very dynamic, enthusiastic, well-funded parent support charity. It's called the Charlie Foundation. I'll come back to that. The second was very good, high-quality, multi-center, not just one center saying, hey, it works at our hospital, but multiple centers getting together and really trying to look at where it works best and how it works best. And then the third, I think, was patience. My mentor, John Freeman, would often get very frustrated at some of the meetings and would go up and say, look, people are really not interested in the ketogenic diet. How can we change it? And he'd get sometimes pretty angry. And I think it took our community just taking a step back, putting things out there, letting kind of the build grow and grow and grow, and it took some time. So in November 1993, the Charlie Foundation was formed. That's their website. They just had their 25th anniversary. And this was the combination of a father of a child with intractable epilepsy who was treated at Johns Hopkins, where I work, and the combination of an angry father who wanted it more widespread and a Hollywood movie producer is not a bad combination. So Jim Abrams made Police Squad, Airplane, Naked Gun, a lot of great funny movies. They're still popular today. And he also had friends in high places like Meryl Streep, and they made a movie about the ketogenic diet and a Dateline special, which probably was really what got the impetus going. And then all of our phones lit up very quickly after that happened. They were the first to help sponsor our first gathering and our meeting. They were really the primary sponsor. You can see their logo in the bottom right, which was held in 2008 in Arizona, first ketogenic diet conference for neurology. And really, if you look at sort of when the explosion in ketogenic diet research occurred, it was around 1994. I think most of us in the field don't think that's a coincidence. It was really right around the Charlie Foundation, sponsoring research, sponsoring studies, but getting the word out so that parents came to be in our research trials. Hard to find a parent like that, but if you get one or an adult or a family out there, grab them. The second thing was getting good quality research trials. These are the very highly cited 4 randomized controlled trials. Ketogenic diet versus medications as usual. Ketogenic diet much higher in terms of just continuing medications in those children. It's gotten a lot of press. There was sort of an argument out there amongst some of the neurology community. Well, that's great, Eric, multi-center, prospective, but nothing is a blinded or randomized trial. That's over. That argument now, we just don't hear that anymore as a result of these trials. In fact, in 2012, a famous group called the Cochrane group that looks at all of the evidence for these trials weighed the evidence pro and con for ketogenic diets. They went on to say these studies suggest in children, specifically children, the ketogenic diet results in short to medium-term benefits. So they didn't say long-term, and we're working on that, but at least short to medium-term benefits comparable to modern anti-epileptic drugs. We actually didn't even think they'd throw that last little bit there in their sentence. So wonderful. Insurance companies say, we're not paying for the ketogenic diet admission. I give them this article. Things happen very quickly. We also got together as a group and put some guidelines out. We're about to revise these back in 2008 from dietitians, neurologists, just saying like how best can we do the diet safely and effectively for children. And I'll come back to that document a few times during my talk. In addition, the basic scientists, who we really hadn't seen for maybe 10, 20 years, are really now a big part of our ketogenic diet community. They work with mice, I work with children, but we talk to each other, we like each other, we learn from each other. And for 20 years, this was why it worked. Patients would say, or physicians would say, well, you don't know how it works. And I'd say, yeah, we have ideas, but we know something to do with ketosis seems to improve seizure control. Maybe it acts as an anticonvulsant drug, having blood ketones, which we know get very easily into the CSF space. You see that elevated fatty acids, chronic ketosis, anticonvulsants. We check urine ketones, and that's the magic. This is where we are today. You have the PDFs. Don't try to take a photograph of this. But this is Susan Messino and John Rowe's slide that they've reproduced, and every time they update it, more boxes, more arrows. But it's complicated, and I think that's a good thing, and we'll come back to that as well. There's probably multiple mechanisms of action, at least in my world, for why these diets help epilepsy, and we'll come back to epilepsy is a very complicated disorder with hundreds of etiologies for epilepsy. And for one type of epilepsy, maybe it is ketones. But for another type of epilepsy, maybe it's keeping your blood sugar stable. There's good evidence for a lot of these things. But as you can see, there's lots of potential targets. And again, the pharmaceutical industry knows this and is actually starting to ask questions for us in the ketogenic diet community, saying maybe we need some new drugs that are more what we call metabolism-based treatments, not calcium channel or GABA or sodium channel. So it's kind of an exciting time to have basic scientists and some of these pharmaceutical companies getting interested in keto research. So sort of for the remainder of my talk, I give you sort of an overview of sort of where we are today, how do we do it, why do we do it, and for who do we do it. And then I'll be here during the Q&A to answer questions if you have any. So how do we start it at Johns Hopkins and most centers around the world? So traditionally, sort of one slide, so to speak, this is how we start the ketogenic diet. We usually bring these children into the hospital, usually in groups, so we do sort of group teaching of the parents. Generally over 2 to 3 days, they come in on a Monday, go home usually Wednesday afternoon. Most of the time is actually teaching. Most of the time is my dietitian, myself, my nurse teaching the families how to do the diet so that when they go home on Wednesday, they are the pros. They're the ones doing it for themselves and can also act as advocates to their pediatricians and their local neurologists. The families are, again, educated with classes almost throughout the day. We start them on ratios of ketogenic foods with weighing and measuring. So they go home with a gram scale. The hospital gives them a gram scale. So extremely precise. Calorie and fluids are monitored, but not usually limited anymore. So we kind of try to target their calories based on what the child was eating before, and we put them usually on a 4-to-1 ratio. That's almost the default ratio. So very high ratio ketogenic diets. And then 3-to-1 we tend to reserve for the infants where I maybe want to give a little more protein. I know you heard from Steve Finney and others about ideal protein. We kind of use about the same, 1 to 1.5 grams per kilogram. And with a 4-to-1 ratio, it's sometimes hard to do that for an infant. So we may do sort of a 3-to-1 or a 2-to-1 ratio. And you can see some of the photographs. That's actually in the bottom from Johns Hopkins Hospital Dietary Services. Not as appetizing as I'd like. We're working on that. But you can see there's butter, applesauce, bacon, of course, scrambled eggs. But if you look carefully, you can see that the kitchen wrote 15 grams, 11 grams, all very precisely measured. We have lots of formulas, and this has really also changed dramatically the ketogenic landscape. About half of our children are either infants or gastrostomy tube children, some of them very disabled. So they're on a formula. I'm just switching their formula. I don't make it easy. I don't say it's easy, but it's relatively simple for my dietitian to recalculate. You can see there's many different formulas to choose from. Some have slight variations on each other, the protein source. Some are trying to be a little more hypoallergenic, which is popular among most families. Some, as you can see here, are in languages that I do not understand. So it's, again, available all over the world with different formulas out there. Some patients will actually use these as a shake. I know there's some shakes out there in the kind of convention area that you can try. Some of our families will use that in the same way, so kind of as a shake to kind of drink during the day or school day. In addition, there are actually now today multiple ways we can do the diets. As we say sort of in our community, there's sort of 4 standard diets. There's some variants on even each of these, with sort of the standard kind of quote-unquote normal diet on the left with carbohydrates in yellow. They're all variants of the same theme. Some families say, I want the modified Atkins diet, or what we call the low glycemic index treatment, which was created in Boston. They're all kind of the same. They're all generally high-fat, low-carbohydrate diets with sort of various levels of ketosis that are created by these diets. They're all generally sort of in sort of the right area. Those 4 designed to be outpatient approaches generally for teenagers and adults who want to try diets that give a little more protein than sort of the standard ketogenic diet. Maybe a little safer, but we don't know that yet for sure. We follow these kids very closely. They email me almost every hour sometimes. But that's okay. They get used to it over time. Some have emailed me already this morning. They're seen every 3 to 6 months. We see them back in clinic. That's my team there in the photograph at Hopkins. They see me. They see a dietitian. They sometimes see my nurse. We get labs generally every 3 to 6 months. And then after a year on the diet, we space it out a little bit more. But we really spend a lot of time discussing not just the diet, but their medications, how they're doing, quality of life. Is the diet sort of meeting their expectations in the clinic visit? And generally in children, which is great, a lot of kids outgrow their seizures. Okay? Even the really severe epilepsies sometimes can get better over time. So we tell families if it works, it's about 2 years, although we can go longer if we need to. But if it doesn't work, after about 3 months of trying, we'll stop it and try other things. And so we tell families this is not a last resort. There's lots of other options out there. So who should go on the diet? Okay, sort of a big question that has come up. So first, before I even do that, what's epilepsy? Just for you guys as a community, it is extremely common. You heard about diabetes being very common. Epilepsy is just about as common, especially in children. There's a peak. It decreases sort of during adulthood and then actually peaks again in the elderly. Epilepsy is very common. It is periodic, unpredictable. So looking at someone with epilepsy, you wouldn't know. Okay, it's a paroxysmal disorder. It just happens and then they're totally back to normal maybe a few minutes later. Many causes, hundreds of causes. Many of them now we recognize are genetic. It is not a problem of obesity. It is not a problem of carbohydrates. Sometimes parents ask that. They say, should I be just cutting my carbs? A child who's seizure-free. I say, I think you probably should, especially after this conference. I say it's probably healthier for you, okay? But that's not the problem causing epilepsy, but it is a treatment sometimes if we have to go to that approach. And I think they get that. It is a common, again, but very private condition. And this comes up when we do switch their diet. This now becomes a little less private. Medications, you can sort of take your medicine at home, at school. Sometimes the nurse can give it. But being on a special diet does sometimes cause a little bit of stigma. So we do have to be aware of that in our world. And the spectrum of severity also is very different. There are some epilepsies that are extremely mild. We may not treat at all. Okay, it's one condition called benign Rolandic epilepsy. They have a seizure maybe once or twice a year. They outgrow it. We usually don't treat them. Okay? And then there are some epilepsies, hundreds of daily seizures. Very, very different kind of scenarios how we approach that. But you can see that's actually the bottom over there, 1 in 26. That's from the Epilepsy Foundation. Kind of really trying to get the word out. But again, it's a private condition. We don't have a lot of advocates, a lot of celebrities. It would be nice, but a lot of them don't want to talk about it. The seizure-free rate with medications in adults is pretty good. Okay, so most of the time we start with medication, and that's actually appropriate. You can see there in pink, about half of patients, you open the bottle, the seizures go away. You don't need much. Okay, same for children. Okay, but then if you have to go to a second medication, you can see sort of in sort of the light blue, an additional 13% will respond to the next medication. So adding all those up, that's about 60% of the kids that really don't need to be on a dietary therapy after 1 or 2 drugs. But then as you can see there in yellow, that's where I come in. Okay, if the medications are not successful, we talk to them about, as we call it, what's plan B, okay, if medicines are not helping. And there actually are 4 major therapies besides drugs, and there are drugs that are in trials. There's dietary therapy. I'm sorry to show this before lunch. There's a brain surgery slice image as well. That can be very successful in some patients. And then using electrical stimulation, something called the VNS. And all of these options are available. We use them all in children. And they can be very effective. And which one we pick really depends a lot on the parents. What do the parents want? Do they want to try diet, or do they want to maybe try something else instead? In table 1 of our consensus paper, maybe the most important table, not just for our paper, but I think for acceptance in the neurology community, again, maybe a lesson to sort of the group, was who ideally should go on the diet. These are conditions here. I don't expect you to know all of these, but these are epilepsy syndromes, some genetic, some are metabolic, where we know the diet is exquisitely efficacious. Not maybe the 50% response rate that most children have, but in some cases like GLUT1 deficiency, 95% response rate. Those kids need to be on the diet as soon as possible. Maybe 1 drug at most before you get them to the diet. Neurologists have accepted this. I get calls from neurologists who maybe don't even use the diet much, but they know about this table. They say, hey, Eric, I've got a child with GLUT1 deficiency. I think I need to send him to you for the diet. I say, absolutely. Okay, and so knowing this, I think, has been really helpful for the neurology community. Even if they're not using the diet in their practice, they're aware of those situations where they should be sending patients in. What's new? So infants are kind of a hot new topic. As you saw, there's many formulas out there. We can use those in infants. And so there's actually guidelines that came out last year for using ketogenic diet in infants. What's the big question parents ask? Breastfeeding. How do they do that with ketogenic diet? Tricky. Okay, you can sort of breastfeed for a few minutes, then switch to a formula, or express the breast milk and then mix it with the formula. There's lots of approaches dietitians, very creative ones, have come up with, but it's an extremely hot topic. So you got infants on one end of the spectrum, and then on the other end of the spectrum, what's really hot and exciting now are adults. Okay, obviously most of you group are taking care of adults, but in the ketogenic diet world, that's kind of a new idea. Using ketogenic diets for adults with epilepsy, even though it goes back to the 1930s, it really fell out of favor with new drugs and new options. This is a photograph from our Adult Epilepsy Diet Center. We need a better name, but we call it the AEDC. That's Mackenzie Cervenka in the back, who's an adult epileptologist, and I sort of help her, but she's really the one running the center, and you can see she's teaching adults how to do, in a group teaching session, usually the modified Atkins diet. This center has now been in existence for almost 8 years. We've seen now probably about 350 adults, many of them extremely intractable epilepsies. I think some of my children are intractable until I see these adults who are super, super refractory epilepsies. About 80% of them have never been offered a dietary therapy for their epilepsy before. And the sad part is many of them had epilepsy even in their childhood, but just wasn't mentioned to them as an option. They now are in their 20s and 30s. They say, why not me? I say, sure, you could do it. There's no reason as an adult you can't do these diets. There also are some contraindications to dietary therapy. We try to screen some of these out, sometimes successfully. Sometimes we do start the diet, see a problem, and end up figuring out they did have a metabolic condition. Most of these contraindications, as you can see, are metabolic conditions. Not really epilepsy conditions, but more metabolic conditions. You heard about carnitine earlier. There is a condition, primary carnitine deficiency, that can rarely cause seizures in children. If I put them on the ketogenic diet, they will die. Okay, so that is very important to screen out a primary carnitine deficiency, fatty acid oxidation defects. Most of these, if you know the etiology, I'm not worried they also have a coincidental fatty acid oxidation defect, but we are very careful to try to screen some of these out. There are some relative contraindications. Most of them are non-compliance or children who are extremely underweight. Most of my epilepsy patients, again, are not obese. They're normal weight. Some of them are underweight for various reasons, and so we just have to be very careful how we put them on these diets. There are some side effects, so we spend some time, actually a lot of our teaching sessions with these parents are explaining to them what the potential side effects are so they can watch out for them. And if they see them, call us right away, call their pediatrician right away, get them in to see us. The side effects that we see, and again, recognize these are, again, non-obese children. Some of them are nutritionally at risk. Many of them have developmental disabilities. And this is, again, with the classic, for the most part, ketogenic diet. And we think some of these are probably better with modified Atkins or lower glycemic therapies. Yet we still do spend a lot of time explaining these to parents. The common ones up on the top tend to be more GI related. So my pediatric gastroenterologist is on my speed dial. I know them very well. A lot of them have some nausea, some constipation, some acidosis occasionally can happen, reflux. Most of this gets better. Most of this gets better after a month or two. But if you don't explain to the parents that this could happen in the first 2 or 3 weeks, they're going to have a problem, stop the diet prematurely. Some of the more sporadic ones are ones that we seem to be finding some success with supplements or changing the diets. Kidney stones, and I'll come back to that one. Growth slowing, dyslipidemia, I'll come back to as well. And then there are some rare side effects, mostly from vitamin or mineral deficiencies in children who are not taking the vitamins that we prescribe. And so we spend a lot of time explaining to them they must be on a multivitamin, calcium, vitamin D. Selenium has recently come up as something we're seeing some selenium deficiencies too. Copper we had recently too. This is actually in adults. This was a paper published just looking at just basic lipid profiles in adults on ketogenic diets, again, mostly modified Atkins diet. And you can see the initial bump in total cholesterol, triglycerides, HDL is the bottom left, and then actually triglycerides are the bottom right. So actually they do dip a little bit, like I know most of you know. But generally they normalize by 6 months. We see this in children, we see this in adults again, and they're on a, again, 80% by gram fat ketogenic diet, yet by 6 months, usually they normalize. So I get a lot of phone calls from other ketogenic diet centers. I have a child with elevated lipid profiles. What should I do? My most common approach is wait. Just give it a few months. Usually it comes back down to normal. If it doesn't, sometimes we'll add carnitine, we'll change the fat source, we'll maybe lower their ketogenic ratio. Long-term effects we really don't know. They're more obviously concerned in adults, but in children, we don't have a lot of worries, at least right now, of long-term cardiovascular effects. What really has gotten us excited are supplements, using different supplements. Oral citrates we use in every child on the ketogenic diet now. They drop the risk of kidney stone from 6% to actually it's now probably less than 0.5%. So we used to see kidney stones about 1 in 20 children on the classic ketogenic diet. Not as common on modified Atkins, but could still happen. Some of our seizure medicines, onisimide, topiramate, can also increase your risk of kidney stones, so that's a concern. But with the use of oral citrates, we're actually seeing a whole lot less kidney stones. And again, the goal of all of this is trying to make the diet safer, more effective, and by using these supplements and changing the diet as we go, that usually lets these children stay on the diet, at least till we can see if it's helping them. And this is table 4 from our consensus paper. The new revision will probably have a few more supplements in it, but this was from the 2009 version. And you can see most of the supplements, as you can see here, are optional, so center by center can decide. But we tend to use a lot of these as well at Hopkins. All right, and then last but not least, I'm doing well for time, what's the future? Sort of where are we heading with ketogenic diets for children? Just to give you a little taste of something that I'm excited about and see if you have ideas, I'm glad to hear some of them too. You remember that world map I showed you? Okay, so here in dark now is a photographic reverse image. Okay, the countries in dark are those that do not offer ketogenic diet therapies. Most of the time it's due to cost, due to availability. Some countries do not have a dietitian. They say, how do we do that without a dietitian? And so sort of in the next phase of my career, hopefully I'll be around to see it, my goal is to make this all go away and all of these dark countries be colored in, and so that anywhere in the world they can offer ketogenic diets, they can. There's someone who can help them. So how do we get there? I think the internet has been amazing. It's really been a big change for our families. Even in these developing countries, they may not have food, they may not have medications, but they all have smartphones. It's pretty amazing. And these parents are emailing us from these countries with like questions. It's pretty cool. And so the International League Against Epilepsy, one of the large groups around the world, has taken an interest in dietary therapy. And this is actually a website that we run through the ILAE. If you Google and you type in ILAE and ketogenic, this comes up usually right away. That's what I tell most people to do. It has sites, has lists of centers around the world doing the diet, has books, has a lot of materials translated into other countries. One thing that comes up a lot in developing countries is they don't have access to our articles. They don't have a subscription to the journal. So most of the journals that have ketogenic diet articles were kind enough to donate these as PDFs. So you can click on the website and download these articles for free, which is really nice. The journals were really good about it. This is our task force. It's the IAE Task Force for Dietary Therapies. We have someone from every continent except for Antarctica. We're working on that. And so we get together and we talk about, again, ways we can bring the diet all over the world. And there's unique challenges. What may work in Africa may be completely ineffective in the Caribbean. And so we have to learn from each other what cultural changes, what religious changes, what food changes. Some of these foods don't have food labels in some of these countries. How do you figure out exactly what they're on? Sometimes you have to wing it. And so we're looking at that too. Can we bring the diet down a notch a little bit? This was a paper we put out looking at taking our consensus paper, but taking it down a little bit and saying, okay, maybe you could do it without all those labs. Maybe you could do it without a dietitian, but here's some ways to do that and how to make it effective. And these are some articles that have come of this recent. You can see 2014, 2016, really kind of a new idea. Very exciting to see the diet being brought to some of these countries that really didn't have it before. And so, again, hopefully this will be continuing to change over the next few years. Lots of great books in many different languages. I didn't see any of these out there. Some of the books that I've seen out there, though, would be amazing for some of our families, especially those recipe books. It's pretty incredible. You can see some of these are recipe books from other countries. Israel, Hong Kong, I see down at the bottom, Japan. So lots of materials out there if a family contacts you. And yeah, maybe they don't have epilepsy, but they're looking for recipe books. There are some in other countries that are available. If you found this interesting and you want to learn more, certainly, I won't say no, Jeff, come to Lowcarb Rec next year, but you could also come to Korea. It's a little further away, not as high elevation. So this is going to be our meeting in October. Again, we meet every 2 years as a neurology community. This is actually our first meeting outside of US and Europe. We're excited. We're a little nervous to see how it goes. It does look like that. Apparently it's a volcano off the coast of Korea that is now a resort. Jeju Island, people heard of it? It's supposed to be beautiful, Jeju Island. So it's going to be in October, again, focusing primarily on neurology, using diets for neurology, but should be fun. This is my ketogenic diet team. It really does take a team, both pediatrics and adults, and I've been really lucky over the years to have an amazing team that does a lot of this work, especially while I'm here in Breckenridge. And really, very influential talking to parents and really making it effective for most of the children we see. Thank you.